Hello, I'm Anthony Smith, and we're back again in looking at one aspect of palliative care. We talked in our earlier lecture about the totality of palliative care, total care for the total person. I want to concentrate now on one particular aspect of palliative care, the very important aspect of managing pain, and we'll touch on on this subject. And my aim is going to be to try to help you to manage pain effectively in patients with advanced incurable disease. And here are the three objectives I have: to understand the various drugs used in treating chronic pain, to understand the differences between nociceptive and neuropathic pain, and to have a working knowledge of the introduction and maintenance of pain relief in this patient group. So, our first question is, what is pain? The definition that I like most is this one, and I like it most because it's what my tutor at St. Christopher's Hospice used to tell me. Pain is what the patient says it is. The proper definition, as we might say, is that pain is an unpleasant sensory experience with its basis in tissue damage. Okay, absolutely right. But here is my definition for patients with palliative care. My patient comes and says, I've got pain. My question is not, are you imagining it? Are you thinking about it? It's, okay, tell me more about your pain. So we're talking about whole person care, and we go back to the lady that I talked about earlier, and I want to remind you about Edith with her particular problems. She had physical pain. She had advanced cancer, which had spread to both lungs, and she had pain. When I went to examine her, you remember, I couldn't find any area that was tender or that gave me evidence for what her pain was. And I asked, when did your pain start? If a person has physical pain, they need medication. This lady's pain was, broadly speaking, an emotional pain, a pain brought on by her memory that she had cancer, that she had advanced cancer, that it had been treated by mastectomy, and it still was there. And the treatment for emotional pain is communication. And we'll talk about that in a minute or two. But she also had social pain because her family and the circumstances of her life made things difficult for her. And there was a big part of her pain which was family pain. And then she said, and why has God done this to me? I've been a good Christian, I've gone to church twice a year, why has God done this to me? And the answer to spiritual pain is not another tablet. It's love, it's prayer, it's care. And that whole group of physical, emotional, social, and spiritual is total pain. But we have to look at specific treatment for physical pain. And so we talk about pathophysiological types, and the two broad groups of pain are nociceptive pain, which is due to some noxious influence, some damage that's been caused to the physical person, and that may be visceral due to damage to the heart or the lungs or to the liver or one of the viscera, or it may be somatic, affecting the soft tissue, affecting the bone. And they are different pains. Visceral pain broadly is non-localizing. Somatic pain can be localized to a specific area. Yes, my pain is here, affecting this particular bone, and I can feel the lump underneath. Or it may be neuropathic pain, and neuropathic pain is due to effects on nerves, which may be pressure on the nerve, may be destruction of the nerve, or may be a spasmodic, intermittent pain. And we shall discover that nociceptive pains have a particular character. Neuropathic pain, I often use the term dysesthetic because it means disturbed sensation. And a dysesthetic pain or a neuropathic pain is a pain results from pressure or destruction of nerves, and which is associated with a general pain plus a sensory change. So, someone who has, for instance, a stroke, you may find them rubbing their arm. It's as though it's aching inside. She can't identify exactly where it is, but she rubs because of the pain. It's a neuropathic pain. It also results in a numb area, and that I would often feel is a diagnostic fact to remember with neuropathic pain. So our question has got to be for our patient, what pains has this patient got? For instance, is it a steady general abdominal pain? Or is it a steady localized pain in one particular part of the abdomen, or the chest, or the body? Or is it an intermittent spasmodic abdominal pain? Or is it a pain that seems to be associated with anxiety or fear or loneliness? Different aspects of pain, and we will need to identify what sort of pain it is, where it is, and what it's related to. And that will help us to make our diagnosis not of a disease. We may know the name of the disease, or we may never know the name of a disease. But we need to know what is causing this pain so that we can use the appropriate medications. Very important to pick up that last phrase. Nobody understands this illness. You know, there is one very dangerous place for a patient, and that is he's got a pain, it isn't getting better, it's constantly there, it's apparently getting worse, but it's apparent to this person that his doctor doesn't understand. The nurse doesn't understand. The family don't understand. And he says, nobody understands my illness. And that feels very dangerous for this person. We need to sit and listen to that person and try to get a reason, a cause for his particular pain. So what's the best treatment for each pain? We are talking about 4 different types of pain. Visceral pain, we use the analgesic ladder, and I'm going to explain that to you in a little while. For inflammatory pain, we use anti-inflammatory medicines, paracetamol or the non-steroidal anti-inflammatories. For spasm pain, we will use antispasmodics. For fear and anxiety type of pain, we will use explanation, and we will use time for listening to the person. Perhaps you'd like to think about a patient you've had recently and think about the nature of the pain that he complained of. Was it one of these? And how did you try to help him? I'm going to have a break for the moment for you to talk with your next door neighbour about these sort of pains, and then we'll continue with our talk in a couple of minutes. I hope you've taken the opportunity to talk with your neighbour about aspects of pain. Now I want to go to look at some of these various medications which we might use for pain. I mentioned the analgesic ladder. Here is the World Health Organization's approved analgesic ladder. It's a ladder with 3 steps. We talk about the lowest step, which is mild pain. We will talk about moderate pain, which is the second step, and we will talk about the treatment for severe pain, which is the top step. But I want you to notice that my ladder stands on the ground, and the ground is no pain at all. And if there is no pain, there is no reason to give painkillers. Sometimes doctors feel that if this patient can't be cured, and if time is running out for this patient, then we'll have to start on painkillers. We must start on some morphine. We don't need to use painkillers if there is no pain. We do need to use appropriate medications for the distress that this patient has. But we come back to pain. Mild pain, pain of a toothache, pain of a gout, pain of a headache, pain in a limb. Mild pain requires mild painkillers. Paracetamol, aspirin, the various adjuvant drugs. We'll look at them in a minute. These are non-opioids, non-opiates. How do I know whether my patient has mild pain or moderate pain? How do I know whether I need to go up a step and start on the mild opioids? Well, the answer is very simple. Mild pain is pain which responds completely to the non-opioids. Mild pain responds to paracetamol, responds to aspirin. Yes, of course, we'll need to give them again in 4 hours or 6 hours because the pain comes back, but they are completely removed by the medication. So in that case, moderate pain is pain that doesn't respond in completion to the mild painkillers. And if this patient has pain that isn't completely relieved by paracetamol, I will have to think about something stronger. Codeine, dihydrocodeine, tramadol, one of the moderate pain relieving drugs, which are mild opioids. That's easy, and you and I can get our patient relieved with the appropriate first step treatment or the second step treatment. The issue is, what about severe pain? What is severe pain? I used to be taught that severe pain was pain that somebody had within the last 2 weeks of life. And indeed, my chief used to tell me, you can't start morphine until you are absolutely sure that the patient is going to die in the next 2 weeks. I could never tell. So my patients were at risk of never having adequate pain relief. I need to tell you that just as moderate pain is mild pain not responding to the mild medications, so severe pain is moderate pain that is not controlled by the mild opioids. And if someone has severe pain, they need to move up the step to morphine or to the appropriate equivalent to give relief of pain. It is possible to get people out of pain, and that is what we aim to do in palliative care. Now, I talked about the ladder, and I need to go to the principles of the ladder. There are 4 principles. Medication is given by mouth. We don't go for injected medication if we can avoid it, because that merely adds to a person's pain. Equally, when a person is being protected by injected medicine, they have to get the injection prepared and given. If it's medicine by mouth, they can take it when they feel the need for it. By mouth. Then secondly, by the clock. Medicines last for a given length of time. And at the end of that length of time, they need a further dose of the medicine. Morphine, for instance, lasts for 4 hours in most people. Paracetamol will last for 6 hours. There's no need for a person taking paracetamol to have another dose after 3 hours. But there is need for someone having morphine to take it regularly. So we say that it should be done by the clock. The third thing is that it should be done by titration. We titrate the amount of medicine to the person and the pain that they have. We want to control the pain completely. We don't want to give them unnecessary doses of medication. We will give them dose that is appropriate to their need by titration. And then fourthly, it's using increments. Just because I've got this person controlled on such and such a dose of painkiller, as time goes on, it may be that that pain becomes worse. It may be that the condition deteriorates, and we may well have to increase the dose of the painkiller. And there are standard ways of increasing the dose. Most of the work that I do is with strong opioids because we're dealing with severe pain. And the gold standard for strong opioids is morphine. And we start at a low dose. There's no reason to start at a high dose because it's a severe pain. Morphine works and works effectively. But we have to get the dose that's appropriate to this person's pain. And I will start with a dose of 5 to 10 milligrams, but I remember that whatever dose I start with, it's going to be a 4-hourly dosing. Unless, of course, I'm using a long-acting medication, which works for 12 or 24 hours. But I prefer to start with the 4-hourly medication so that it's more easily controlled. And then we will increase the dose after 3 dosing intervals, 12 hours of 3 doses of 4-hourly. We increase by 50% if we need to. So we've got our 10 milligram start, we will increase to 15 milligrams, and then we will increase to 20, 30 milligrams to get adequate pain relief. If we need to go higher than that, the increment will be 33%, not 50%. And we will need to explain. I always say that prescribing opioids is a package deal. And my packaging requires explanation, it requires an antiemetic to prevent sickness or nausea, and it requires a laxative to prevent constipation. So here we are with my package deal. I'm going to prescribe morphine for this person. The hand that prescribes the morphine also prescribes the antiemetic and a laxative for constipation, to prevent constipation, and an explanation. This medicine is a good painkiller. It will make you feel a bit sick, and we'll give you something to stop the sickness. It may give you constipation. We will give you something to control the constipation, but you need to use them regularly. It will also make you drowsy. And the drowsiness, I would explain to my patient, is so often because this pain that you've had has kept you awake day and night for the last few weeks. Now I'm giving you something to relieve your pain, and your body will say to your mind, you can go back to sleep because I'm out of pain. Don't be worried about being drowsy. That will wear off. It will last for a couple of days, and then it will wear off. But it's a proper part of the package deal. Now, we all know that there are myths about morphine. The first is that it's dangerous. Yes, morphine may be dangerous, but it is not dangerous if it is understood, and if the nature of the pain is understood, and it's appropriate for the pain. It's addicting. It is addicting, but it's not addicting when it's used appropriately for pain. Pain is the natural antidote for opium, for morphine. If I've got pain to here, then I need to give morphine to here to control that pain. Addiction happens when I'm giving morphine up here, when it's being used for pleasure or for other reasons, not when it's being used for pain. Some people tell me, when you start on morphine, you always need to escalate the dose until one day it kills the person. No, not till it kills the person, but till it relieves the pain. We don't go on escalating if the pain doesn't come back. Morphine, they say, always causes respiratory depression. I know that it does cause respiratory depression because I've seen that happen occasionally, but it doesn't cause respiratory depression when it's used by mouth and used in the appropriate dose. I'm not going to go much deeper with different sorts of opioids, but I want to add now something about adjuvants for pain relief, because there are medications that work with the painkillers that help to provide complete relief of pain. And these are the antispasmodics, which relieve spasm pain, the non-steroidal anti-inflammatory drugs, which help with inflammation, steroids, which are very effective relievers of pressure pains, antidepressants, because depression is part of pain, anticonvulsants. We'll come to antidepressants and anticonvulsants in a minute or two. Antibiotics for inflammation, for infection, and bisphosphonates, which deal with bone pain. And we may touch on nerve blocks as adjuvants for pain relief. So, we'll have a break at this stage, and you can just talk to your neighbour about those different groups of medications. Have you used morphine? Have you used painkillers for strong pain? Are you able to completely control pain? And do you understand about combinations? Have a couple of minutes to talk with your next door neighbour. I want to talk a bit about specific pains because we have talked about the various adjuvants and we've talked about different sorts of painkillers. We must now concentrate on relating that to specific pains. And the first group of pains is colicky pains, abdominal colic, the biliary colic, intestinal obstruction colic, ureteric colic. And the essence for these is to use antispasmodics. Morphine alone may make spasm worse. It will certainly increase constipation. So avoid the opioids until you have controlled the colic area. The second group of pains are bone pains. And the first issue for bone pain, if there is a fracture, is that the fracture must be stabilized or fixed. I used to deal with a lot of fractures, and in palliative care we do have limb fractures because of gradual erosion of the middle of the bone by metastatic cancer. I discover that morphine is not particularly helpful. I can get complete control of the pain with an adequate dose of morphine, but then if the person relaxes, the pain disappears and they don't need as high a dose of morphine. And the combination of too much morphine and too little morphine leads to confusion. So we do use opioids, but more importantly, the non-steroidal anti-inflammatory drugs, the NSAIDs, and bisphosphonates specifically for bone pain. So initially, think about stabilizing or fixing the fracture. And then here are medications that once you have fixed that fracture, you can continue to use. Our third specific group of pains are pains caused by infection. And the examples that I give are lung abscess, mouth ulceration, and bronchopneumonia. There is the pain of mouth ulceration is very severe, especially a rodent ulcer, for instance, eroding the side of the cheek, because it's bone pain and nerve pain and soft tissue pain. A lung abscess is also causes pain, and we won't deal with the problem unless we control the infection. So we use antibiotics, and we need to think about which antibiotic. We need to think about our organism that's causing the pain, and we will remember anaerobic organisms which need specific medications. Our next group of pains are liver pain. Pain in the right upper quadrant of the abdomen with caused by invasion of the liver by a tumour. You will remember from your anatomy days that the liver has no nerve innervation. So where is the pain coming from? The pain is coming from the capsule of the liver, which is well innervated and is caused by stretching of that capsule. And therefore we use medications that will relieve the stressing the stretching of the capsule. Opioids can be useful. We may need to come to them. Non-steroidal anti-inflammatory drugs are probably going to be more helpful, but the two groups of drugs that I work with mostly with liver pain are steroids and diuretics. They will reduce the swelling in the liver and therefore the pressure on the capsule and relieve the pain. Use diuretics and steroids for liver pain. What about the pain, the headache caused by raised intracranial pressure? For that, we will need, again, painkillers. Paracetamol may be useful, but the important thing for them is steroids, used in high dosage. And I use dexamethasone 8 milligrams twice a day, quite specifically for people with raised intracranial pressure pain. And then we reduce the dose as the pain comes under control. For vomiting related to that pain, we would use an antihistamine. And now we have the nerve pains, the neuropathic or dysesthetic pains that we were talking about. Pain in a numb area, pain which is a widespread general pain, but with a change of sensation in the area. The medications we will use, opioids, can be useful. We may be able to control that pain with morphine. We may find that we need to add steroids, or we may use the antidepressants or anticonvulsants. Which do we use at first? I would go for opioids plus an antidepressant for aching type pains, or opioids with anticonvulsants for the sharp lancinating pains. And then finally we may go to a nerve block. And explanation. Always explanation to our patients. Explaining what we're doing and why we're doing it confers dignity to the patient. He's not an animal to be treated. He's a person to be shared with. And it reduces fear and confusion. The patient understands why we're giving this. Yes, we may need to persuade him to take the medication, but at least he will understand why we're recommending it. And it leads to and increases trust. Always, when we're giving medications to patients, we need to explain why and what we can expect from it. And then finally, treatment for pain. Effectiveness of that treatment depends on accurate assessment, which is right at the beginning, and depends on three essentials as we go through the care. The three essentials are review, always after 24 hours. How are you? How is the pain? How has the pain been? Preferably before 24 hours, perhaps after the first 4 hours. Has that treatment been effective? Do we need to increase the dose? And the second thing is another review. And so what's the third essential? Another review. So the three essentials, as my friend at St. Christopher's used to say, are review, review, and review. I take the opportunity to introduce this palliative care workbook that Prime has produced. It's available online at www.prime-international.org.uk, and it provides a lot of teaching about the various aspects of palliative care and of symptom management. At the end of several of the chapters, there is a case history and some questions related to that. which enables the reader to apply what they have read to a particular case and helps them to relate it. I hope it will be useful. Thank you for being here. Thank you for listening. Now I hope you'll be able to apply some of what we've been talking about.